Hi, I'm Corey Feldman with the Society for Healthcare Innovation, here with Dr. Patrick Kim from the University of Pennsylvania Health System. Thank you so much for joining us tonight, Dr. Kim. Appreciate your
My
time.
pleasure, Corey.
And so, Dr. Kim, what I think we'd like to hear a little bit about is what your role is in general, kind of what your life looks like as a trauma surgeon, and then we'll move a little bit more into how you guys are preparing for the pandemic moving towards Philadelphia. So just kick it off and let us know kind of what your life looks like as a trauma surgeon at Penn.
Okay, so I'm an attending surgeon at Penn Medicine in the Division of Trauma Surgery, Critical Care, and Emergency General Surgery. I'm the division vice chief, but my clinical practice spans all three of those domains. I do trauma surgery. I spend some time in the surgical ICU. And I take call for emergency general surgery, which is emergencies like appendicitis, gallbladder operations, severe soft tissue infections, and so forth. Our trauma center is a level 1 trauma center. We see about 2,700 patients a year. We have a very busy critical care service and a very busy emergency general surgery service as well. We probably do over 1,200 cases a year emergently.
Wow. And as you think about COVID-19, what preparations are you guys beginning to take? You know, obviously traumas don't stop just because there's a pandemic happening, right? And so what measures are you guys taking to keep the ED safe, to keep yourselves safe, and to kind of prepare for the influx that you guys are expecting?
Yes, Corey, this is, as you know, unprecedented. Trauma centers in general are prepared around the clock, 24/7, to deal with sporadic incidents of trauma and violence, and also mass casualty incidents. And we do preparations to be ready for incidents where a lot of patients are coming all at once, and hospitals in general prepare for disasters. But really, this is something that's completely different. It's not something that we've ever done on this scale before, which is basically to prepare the hospital by clearing out any elective surgeries. We have basically expedited discharge of any patients that who could possibly be discharged safely. As a trauma center, we are preparing by practicing, seeing COVID positive patients in the trauma bay and simulating their care throughout the hospital. We have maintained our manpower, our availability 24/7, while many parts of the hospital, for example, elective surgery, have been curtailed. We're really trying to free up the capacity to deal with this. But really, in general, we're still available to deal with traumas, whether or not the patient is a COVID patient.
Got it. And so are you guys preparing for contingencies where a patient comes in and they have a trauma of some sort, but they might also have COVID? Like, are you guys designating certain entrances for folks that are showing symptoms versus those that are not?
Well, as of right now, they're going to come through the same area through the trauma bay, and we're going to treat them just the same, because in general, we use a high degree of personal protective equipment anyway for every trauma patient, because we don't know what their medical history is, and we actually generally practice these precautions for everybody. So this is not a huge change in the way that we prepare. For example, we do gown, hat, mask, gloves, eye protection for everybody. And now we use a standard surgical mask and regular eye protection. So those things are still appropriate for patients that have not been confirmed to be COVID positive. So if we are doing our assessments and we take a history from the patient and find out that they do have some risk factors, then we switch over to a higher degree of personal protection, including the N95, for example. If we have to do a procedure such as oral tracheal intubation or a surgical airway, the airway teams are appropriately trained in the use of PAPR, the positive airway pressure devices, and also to minimize the amount of time that there's any possibility of aerosolization. So in general, we're prepared for any type of a patient, whatever their risk is, and at the same time, this is completely new, so we're being very, very careful.
So as I was watching these videos coming out of Italy, you're seeing a lot of these doctors, they closed down post-acute clinics, pulled doctors from post-acute into the, anyone that could treat is treating. Are there any takeaways that you've, or things that you've learned over the years working as a trauma surgeon that you think might be relevant to folks who are now going to find themselves in this situation for potentially the first time?
Well, Corey, I think that the important thing is the preparation. One of the things that we're always teaching to our trainees, the surgical residents, emergency medicine residents, and residents in other specialties, is really just going through the drill almost every opportunity possible, and really giving people the education, if they haven't been there personally, to learn from an experience and watch the experienced team do it. Then we have conferences every day where we review the procedures, the best practices, and really try to enforce the readiness. In some sense, I feel like that's the culture of trauma centers and trauma teams, which is to practice everything and learn from every possible opportunity and keep teaching continuously. I think that some of the things that we've learned from other cities and countries where they're ahead of us, unfortunately, is that really the preparation that we do as a team is necessary, but it's not sufficient. We're finding that there's a lot of shortages of supplies, crucial equipment, and even though we feel like we were ready in many ways, I think in that crucial aspect, we're a little bit behind because, to be honest, you probably know this, but many hospitals, especially academic medical centers, are running at full capacity every day, and so we really drill the process on the provider side of things, but in terms of where to put patients, once they require admission, and having a surplus of supplies to meet the demand, I think that we have a learning opportunity here.
Yeah, and I mean, I just saw on the news that New York has basically tapped the Javits Center as a makeshift hospital. And I know New York is probably significantly further ahead in terms of the number of infected folks in Philadelphia. But is the University of Pennsylvania health system giving thought to where this surplus might end up?
Yeah, we've given it a lot of thought. Penn Medicine is 6 hospitals, 3 of which are in downtown Philadelphia, and one of which is in New Jersey, in Princeton. And we're really we've had some time to think and plan about the surge capacity, about patients, filling up the ICUs and then needing to spill over into other patient carriers that are not traditionally used around the clock. So beyond the general med-surg floors, areas such as the operating rooms, the PACUs, in other words, the post-anesthesia units, and other intervention or procedure rooms, anywhere where we can bring the ICU skills and the equipment, the ventilators, the IV infusion pumps, and most importantly, the bedside nurses, advanced practice providers, and physicians. So, we have some contingency plans, and thankfully, we haven't maxed out our capacity at all at most of the hospitals. I think we're in a position, to be ready for the initial influx, and I think it's difficult for us to predict today exactly how much of the surge capacity is going to be used, or how quickly it's going to be overwhelmed, to be honest.
The last thing I wanted to ask you about, we are both in this Master of Healthcare Innovation program together, and while obviously a lot of tragedy has resulted already from this pandemic, and unfortunately will continue to, it seems that there has been some positive movement in the sense that telehealth has been thrust forward in a real and meaningful way. For you, what do you see as kind of some of the takeaways from this experience that might be positive?
That's a great question. Well, I think first of all, address the specific issue of telemedicine, you know, this is probably the worst way to expand the use of telemedicine in healthcare. And I think a lot of providers have wished for a great, straightforward telemedicine solution. And I think now we don't have a choice. So, you know, part of clearing out the hospital and part of keeping people away from the hospital campuses is really to switch almost instantly to telemedicine for any visit, you know, a post-operative visit that's straightforward or an uncomplicated problem. So in that sense, I guess this is one way to move forward, which is basically to eliminate any other choice. So I'm hopeful that that'll be a sustainable change. I will be, I'm impressed how quickly, you know, we've been given the clearance from a licensing standpoint to practice telemedicine. We've been granted emergency privileges to take care of patients across state lines with telemedicine. So all those things I think are going to be very helpful, again, from not just from a patient care, but a public health standpoint. So I'm encouraged by that, and I hope that I hope that we can learn some longer-term lessons about the role of telemedicine. The broader question of you know, what other lessons we can learn from this, I'm impressed by my colleagues and peers' passion and creativity. I think that this is going to have some lasting impact in terms of our supply chain, in terms of the way that we think about ramping up, you know, delivering surge capacity, both with human resources and equipment. I think that, and obviously, I think we're going to innovate very quickly in terms of preventing something like this from happening again. It concerns me a little bit, I mean, because this is the first time any of us have been through this. You know, we look back to the past with the Spanish flu from a century ago and other, the less, the more predictable seasonal flus and so forth. You know, we're always trying to draw lessons from that, but I think that, you know, I think that we won't be as complacent next time and not as skeptical about things happening around the world. I think that, you know, we'll, you know, from this we'll pay more attention, and I think that there'll be a clear mandate for objectivity and transparency in information, and hopefully we won't be afraid of the truth. I mean, you know, I'm inundated with, you know, the breadth of studies and information and sharing of knowledge, sharing of, you know, offering it to help. All these things are very impressive. I mean, you know, the medical students, you know, we have ended their medical school rotations for the year prematurely just to keep them away. But, you know, they've got pent up passion and, you know, energy. And so I think that's great. I think that everyone that I've talked to, you know, they want to be safe, but they want to help. And so I think all those things are encouraging.
Yeah, and I think that's a nice segue. I just want to let you know how grateful and humbled we are by all of the hard work that you guys are putting in as clinicians to keep us safe. So thank you for that.
Well, thank you for those kind words. You know, it's the sort of thing where we always, you know, we kind of do what we do regardless of any feedback, but everyone likes to hear positive feedback. So I appreciate that.
We are the Society for Healthcare Innovation. We were started out of Penn's Master of Healthcare Innovation program, and we are really looking to connect with folks who are bringing innovative solutions, either from a clinical perspective or technological perspective, to deal with the pandemic. So if that's you or someone you know, please reach out to us. You can find us at shci.org, or you can find us on our YouTube channel, which is the Society for Healthcare Innovation. Thanks so much, and have a great night.